Hi everyone, this is Dr. Jake Pace.
And I'm Dr. Samir Mall.
This is your screencast on Airway, Foreign Body in preparation for your Airway Day.
To start things off, we'll quickly go through a review paper which was published in the International Journal of Pediatric Otolaryngology. Essentially, the take-home points from this paper are that airway foreign bodies are a very common occurrence, and the most common age groups you're going to encounter this issue are between the ages of 0 and 3. Surprisingly, this does happen with children who are eating more than playing, and the most common location for these airway foreign bodies are in the right mainstem bronchus, with greater than 50% of cases occurring at this level. The approximate death rate in this review paper from airway foreign bodies was approximately 2 to 3%, so these are not an insignificant problem in our patient population.
This paper shows all the various foreign bodies that have been aspirated in their meta-analysis. What you need to recognize here is there's a vast array of things that get aspirated in the airway. At the end of the day, regardless of what is aspirated, your management approach to this complex patient presentation is the same, and we're going to go through that now. This is the beginning of your airway foreign body. The first question you need to ask is the foreign body causing a complete airway obstruction? This assessment is done by the ability of a patient to phonate, oxygenate, and ventilate. Is the patient able to move air? Are they talking to you? If the answer is yes, and there is an incomplete airway obstruction, you are going to do nothing at this point other than keep the patient calm, keep the patient in an upright sitting position, and call ENT for an emergent bronchoscopy. It is essential to keep the patient calm and avoid laying the patient flat to prevent transitioning an incomplete to complete airway obstruction. If the airway obstruction is complete by the foreign body, you are now moving to a scenario where you're going to perform a maneuver to increase intrathoracic pressure in an attempt to expel the foreign body. This is done through a Heimlich or abdominal thrust maneuver.
And we'll go through this maneuver in both adults and kids in the next couple of slides. So if you encounter the situation with a complete airway obstruction in an infant, step number one, hold the infant in your lap and put the infant with their face down and their head lower than their chest. The infant can be resting on your forearm, and you can put your forearm over your thigh for support. Next, with your opposite hand, support the infant's head and neck, and be sure to avoid putting any pressure on their throat. Using the heel of your free hand, deliver 5 back blows between the infant's scapula. Now, using both your hands and arms, you can turn the infant face up so that they're now resting on your other arm, and this arm can be resting on your thigh as well. Make sure the infant's head, once again, is lower than the chest, and using the fingers of your free hand, provide up to 5 quick downward chest thrusts over the lower half of their sternum. If the obstruction is not relieved, you turn the infant face down on the other forearm and repeat the back blows times 5 and continue in this cycle until the patient either has a relief of their obstruction or becomes unconscious.
If you're dealing with an adult patient who is standing upright and has a body habitus that you can reach all the way around their abdomen, you're going to stand behind that patient and place one foot in front of the other to give yourself increased balance. You're going to make a fist with one hand and place that slightly above the patient's navel and grasp that fist with your other hand. You're going to press hard into the abdomen with quick upward thrusts as if you're trying to lift the patient off the floor, and you're going to perform 6 to 10 abdominal thrusts in an attempt to dislodge the foreign body. If the patient is of a body habitus you're not able to reach around them, or they are laying on the floor, you are going to perform chest compressions of performing CPR until the patient loses consciousness. These are all attempts to increase intrathoracic pressure, which is trying to expel that foreign body from the larynx. If you are alone and in an unfortunate circumstance where you have an airway foreign body, you can perform a Heimlich maneuver on yourself with the backing of a chair, place it into your epigastric region, and perform abdominal thrusts in an upwards direction, trying to increase intrathoracic pressure.
So now we'll go through the middle of our algorithm. So whether you have an adult or a child, step number one was attempting a Heimlich maneuver. And let's say now the patient has unfortunately stopped breathing and become unconscious. Now we go into the next phase of our algorithm. So once the patient has lost tissue tone, you're going to proceed with direct laryngoscopy assisted with McGill forceps and try to see if this object is removable. If the object is supraglottic and in the posterior pharynx, you can use McGill forceps to remove that object. Here's a quick diagram. As I'm sure you guys are all familiar with the equipment, so in the operator's left hand there's a direct laryngoscope, in the right hand you see the McGill forceps, trying to retrieve a foreign body that's at the level of the cords. Gently remove that foreign body and hopefully you will have relief for your patient.
If you're in a situation where the object is unremovable because of its location in the subglottic space, the next maneuver is an intentional main stem intubation. What we're attempting to do here is to push the foreign body into the right main stem. After the tube is placed in the right main stem, which is achieved by inserting the tube into the maximal depth that it will insert with gentle force, you're going to reposition the tube into a location above the carina and attempt to bag the patient. If you are able to bag the patient, you're going to proceed with post-intubation management, which will include sedation, and the patient will transition to the OR for bronchoscopy with either respirology or anesthesia. If after repositioning the tube in the supracarinal space, you're still experiencing a lot of resistance with bagging, a potential issue is that the foreign body has become lodged in the end of the endotracheal tube. In this situation, the recommendation is to extubate the patient and get a new endotracheal tube and re-intubate the patient. If with the insertion of a new endotracheal tube is unsuccessful due to high airway pressures, we're in a last-ditch effort where the hope is that the patient has developed bilateral pneumothoraces from barotrauma in the attempt of bagging and manipulating their airway. In this situation, we would recommend bilateral finger thoracostomies to decompress each thoracic cavity and with continued attempts at bagging the patient.
So just to quickly summarize this algorithm, right? So you have someone present with an airway foreign body, an adult or a child. If they're still able to phonate, they're tolerating their secretions, they're not drooling, and they're moving air, call for help. You got some time. If they actively start choking and are unable to do any of those things, you're going to try to increase intrathoracic pressure. That fails, they go floppy, use a DL and try to remove the object if you can, if it's above the level of the vocal cords. If you can and it's below, try to push that object down into the right or left mainstem bronchus, reposition your tube. If that's successful, great, you're done, patient going to the OR. If you're not successful there, switch your tube out in case your tube has become obstructed, and lastly, finish with bilateral finger thoracostomies.
We hope you guys took something away from the screencast and have some questions to discuss at Airway Day. We thank you for your attention and look forward to seeing you guys in the next couple weeks.